last lecture, I discussed the formation of atherosclerosis within blood vessels, and how that atherosclerosis can lead to the formation of a fibrous of a plaque which has a fibrous cap, and how the rupturing of that plaque can then lead to conditions such as acute coronary syndromes. So today I'm just going to discuss acute coronary syndromes. Acute coronary syndromes, I should have just written ACS. So acute coronary syndromes arise from, as previous, like just a previous recall of a vessel lumen which now has a formed plaque, and a plaque will usually, an atherosclerotic plaque is usually really filled with lipids inside. So I will have a lipid core, and the top there will be a fibrous cap. And the fibrous cap, recall, is made out of smooth muscle cells that have merged from the media to the top, remember, based on the layers of the blood vessels. So during say strenuous activity, or something like emotional upset, which results in increased catecholamines, will then cause increased heart rate. And obviously increased heart rate also causes, shall we just write that, say whatever, whether it's physical activity, anything which causes will cause increased release of catecholamines. Cholamines. Today I cannot spell from on life. So increased catecholamines then bind on their receptors and results in increased heart rate, increased blood pressure, and increased force of contraction. And obviously, when all of this is happening in a cardiomyocyte, it leads to increased oxygen demand. And obviously, this increased oxygen demand has to be met by all of that. And if we're talking about a vessel that's suffering greatly due to a reduced lumen, when all of this is happening, it will obviously cause a lot of pressure and a lot of shearing in that vessel. And that increased pressure and increased instability, shall we just say hemodynamic instability, causes this, puts the plaque under a lot of stress. And usually when the plaque is under a lot of stress, then the propensity of rupture is increased. And with the plaque, really some of the most important points to remember is that its shoulders are terribly vulnerable, and they are vulnerable obviously to the turbines, to different forces working, to the changes in pressure and the changes in contraction, vasoconstriction and vasocontraction. Therefore, this plaque ruptures, let's just say it's rupturing, then causes a thrombus formation. We now have an let's say coronary or whatever, intravessel coronary thrombus forming, and which obviously leads us to the acute coronary syndromes. And the acute coronary syndromes really all have the same pathology, in the sense that they all begin with formation of a plaque, rupturing of a plaque, and then the only difference with the acute coronary syndromes is what happens in the lumen. For example, let's say we have our lumen there, and then we now have a thrombus forming, right, in that occluded. So if there is partial occlusion, as in there's still room there for blood to squeeze through, we will have either unstable angina, and we will have a non-ST elevation myocardial infarction. So these are the two that we will have, and these two are part of partial occlusion. This is partial occlusion of the lumen. However, if we have complete occlusion of the lumen and there is no way for blood to flow, we then have an ST elevation myocardial infarction. And although the pathology, the underlying pathology of these two, like from the beginning, is exactly the same, the difference is that we have a complete occlusion here, and therefore we have a patient who's in a lot of trouble and they need immediate reperfusion of that vessel. Whereas with these patients, we do need to stabilize them, we do need to manage these clots, but however, they are not in as much trouble as the patients who are in a STEMI. However, it's important to know that an unstable angina or a non-STEMI can indeed develop into complete occlusion. So really, both of these patients are in trouble and we need to help. So now let's just talk about, now that we know the difference between the two, I also did really want to focus on other things that I haven't focused on. For example, the formation of the thrombus. I'm not going to go into a lot of detail on the coagulation cascade, because I tend to like to do that as part of hematology, and as part of doing all the measurements that have to be done. So I'll just briefly look into that. So I have mentioned about the formation of a thrombus. So a thrombus obviously is a blood clot, and a blood clot comes from when this ruptures, say when the fibrous cap ruptures, it exposes, number one, collagen. Collagen becomes exposed, and it also releases, like the smooth muscles. Let's remember, this has smooth muscles, and smooth muscles release tissue factor. So now we have two things really that, as the minute we hear the word tissue factor, shall I write this in full? The minute we hear tissue factor and exposed collagen, our brains immediately gets triggered into thinking, oh dear God, platelets will be activated. Oh dear God, the tissue factor pathway of the coagulation cascade will be activated. And that is true. So once all of this happens, exposed collagen causes platelet activation. Remember, blood flow always has platelets. So once collagen is exposed, it exposes binding sites on the endothelium, and platelets begin to bind and become activated. So now we have binding and activated platelets. And when platelets become activated, they will release serotonin. They will release thrombin. They will release thromboxane. They will release fibrinogen. They will release factor 5, and they will release ADP, and well, they will release other things as well, such as histamine and growth factors. So now we have all of these released from, and also, most importantly, they will release van Willebrand factors. So now we have activated platelets that are releasing all of these. And obviously we know that these three are potent vasoconstrictors. Particularly thrombin is a potent vasoconstrictor. And then we know that fibrinogen and factor 5 and van Willebrand factor really are all going to contribute to the coagulation cascade. And then let's just say these two will mostly focus on platelet activation, obviously thromboxane as well, so that's like platelet activation to propagate the activation of platelets. So now we will have exposed collagen, activated platelets, released tissue factor, and obviously tissue factor, once tissue factor is released, it will activate the tissue factor pathway, which is mostly responsible for activation of factors, all the vitamin K dependent factors, including factor 9, factor 7, and factor 10, which is part of the common pathway. I can't remember if factor 5. No, let's just leave it at that. Factor 9, 7, and 10 will be activated via the tissue factor pathway, and all the other factors will be activated via the extrinsic pathway. So then now we have the activation of the tissue factor pathway, which means that we're already entering into the coagulation cascade. And the effect really of I need space, unfortunately. The effect really of the coagulation cascade, which I had said I wasn't going to discuss in full because I haven't really revised it terribly well. The effects of the coagulation cascade is to have the factor 5A and factor 10A complex, which is the activated complex, which then goes on to activate thrombin from prothrombin And once we have active thrombin, we can then convert fibrinogen to fibrin, which is converted by thrombin. And what thrombin also does is obviously activate factor 13. So I suppose we can say factor 13, again by thrombin, which obviously forms the activated factor 13, the cross-linking of fibrin to stabilize the clot. But obviously before we actually do all of this, I'm actually going to wrap this out, because this is obviously the part 2 of the coagulation pathway. Oh no, this is part 2 in fact of the coagulation pathway. But part 1 involves platelet activation and platelet aggregation. So let's just write part 1. Again, we're still here. So it's all to do with platelet activation and aggregation. Oh, should I have just written platelet in full, because it now looks like I'm talking about a patient. Platelet activation and aggregation. So in terms of platelet activation and aggregation, we will go back to having an activated platelet. So this is a platelet, an activated platelet. So activated platelet will obviously have binding receptors, binding sites, and that sort of thing. For example, on the endothelium, say that is the endothelium, van Willebrand factor will bind the endothelium and also bind on the platelets. So to actually cause platelets to become to promote platelets to become tethered onto the site where there is a bleed. And then there is also the let's try and use a different pen. There is also the GP2B 123A receptor that are found on platelets, and again they are used to link to cause platelet aggregation, and this aggregation via this GP2B 3A receptor is quite important, because it houses in between the two platelets fibrinogen. Which is obviously not activated. So we'll have this scenario. And platelets also uses other GP, such as GP1, I can't remember the number now, to also bind on the endothelial surface. So now we'll have, this is how platelet aggregation actually happens. So platelets will use its own receptors to bind together and to bind and to form a bridge, a link for fibrinogen. And obviously platelets will continuously make themselves become even more activated via the secretion of things like ADP, growth factors, and other substances which promote their own activation and obviously the propagation of the aggregation and activation. So then now once we have that, this is part one of the coagulation cascade. We then come into part two, where we now have formed an active factor 5A, factor 10A complex, which activates thrombin, and then activated thrombin then comes here on there. So this is thrombin, and activates fibrinogen into a fibrin mesh. So then we'll have like platelets there, let's just say. Oh, I should have made platelets in black to be consistent. So we'll have all of this, obviously goes on, nothing stops. This is a cycle that keeps going on and repeating itself. So we'll have platelets that are aggregated on top of a bleed, on top of that exposed endothelium, on there, like on that rupture. So we are having this, our platelets there to try and maintain the bleed and to try and repair really the ruptured site. So our platelets are aggregating there to cover that area where there is the injury. So these are activated platelets which have aggregated. And the next thing, once we have fibrinogen becoming fibrin, it comes on top there and forms a mesh to stabilize this whole thing. So this is the aggregation of platelets is actually sort of not really stable. So this is not, we can call it like temporary. But then once a fibrin mesh forms on top, it becomes much more stable. And also recall, thrombin also then forms these cross-linking bonds and fibers to actually fibrin plus cross-link. So thrombin forms two things. It will form the mesh, and then also forms the cross-linking, so that we finally have a stable and managed clot that manages the bleeding and repairs the injured site. However, it also has disastrous consequences, in the sense that it can occlude that tiny lumen which is already compromised by an atherosclerosis plaque. So really, if this was to happen, say, because this happens anyway normally when someone becomes injured and they bleed, if it happened in a normal healthy vessel where the lumen doesn't have any atherosclerosis, all that will happen is the injury will happen and repair will happen, say like that, but the lumen will remain patent and blood will still be able to flow. So really the most important thing about the acute coronary syndromes is that when all of this repair mechanism, which is a normal body mechanism to repair site of injury and stop blood loss, when it happens, it actually happens in a compromised in a compromised vessel, and therefore we end up with an acute coronary syndrome. So now we have discussed the two different types of acute coronary syndrome and how, as an ST elevation, acute coronary syndrome is due to the complete occlusion of the lumen, whereas unstable angina and a non-STEMI is due to partial occlusion. So now we'll just briefly talk about why we call it a STEMI and or how we can in fact differentiate between the two. So it's obviously called a STEMI based on ECG findings. This is ST segment elevation. So now which obviously then brings us really back nicely to discussing how we diagnose this and how we differentiate between the two. So obviously when a patient comes in, they are presenting history and they are presenting complaint, and their history will let us know that we must be suspicious of an acute coronary syndrome. For example, the patient will describe severe substernal pain that radiates to the jaw, the neck, the shoulder, and the arm. And in terms of the arm, really, it's usually the C7 dermatomes to T4. So it's basically really substernal around the nipple area, in the middle, obviously, and coming into the C7 dermatome, which really is more like medial of the arm. So they will describe that pain. They will also have perhaps a history of angina that is usually resolved using perhaps a GNT spray. They will probably have a history of dyslipidemia of some sort that we probably already know of, and they will also have increased heart rate, be clammy and sweaty, obviously due to the activation of a lot of other body systems to try and resolve what's happening, for example like sweating, to try and cool down the patient. They will also have a slight fever, and if they're able to talk, they might describe, how all of this happened, or if there is someone there, they might say what happened. So the tests that we'll need to do, the investigations that we'll need to do, are the cardiac enzymes or serum proteins, really. And the specific ones, the cardiac specific ones, are the troponin I and troponin C. We will also have to check the CK-MB because it is specific for cardiomyocytes. However, obviously CK-MB is also found in in the uterus. It's also found in the prostate. It's also found in the diaphragm and on the tongue and in the gut. However, the difference with if it's a cardiogenic CK-MB elevation, it will be raised more than a ratio of 2.5. So that's how it becomes much more specific for cardiac. So that's how it becomes much more specific for cardiac. We will also do investigations such as ECG, and obviously the basic investigations such as heart rate, temperature, send off for bloods. But then these two are the more specific for diagnosing acute coronary syndromes. And in the ECG, we will find either ST elevation which will look something like this. Oh yeah, I think I'll just do it from here actually. So this being the baseline, and obviously I've done a pathologic Q there. So they will have an ST elevation and a pathologic Q. Pathologic Q. And obviously the pathologic Q is a sign of necrosis really. And on the ECG really, this is the findings of a STEMI. And ST elevation happens very quickly, really within hours, about 3 hours. So by the time we do this investigation, if it's a STEMI, ST elevation will be there. We expect to find it, and we will expect to find it on the responsible ECG leads. For example, say if it's I think pericarditis, I can't remember, pericarditis also presents with ST elevation, but the ST elevation is much more diffuse on all ECG leads, so it's not specific. However, a STEMI ST elevation is actually specific on the site of injury. Say, I don't know, say if it's anterior, it might be V1, V2. If it's inferior, again, we'll find it in the inferior leads, 1, I think. Oh god, now I should not have said that. AVF. And then if it's lateral, again, we will find it on the lateral leads. So it always is going to be absolutely specific. If it's a non-STEMI, however, if it's unstable angina, there will be no ST elevation. So that's how we will differentiate between the two. This is the pathologic Q. There will be no ST elevation, but there will be a T wave invasion. So our ECG for a non-STEMI, an unstable angina. So in terms of ECG, this is how we will differentiate between a STEMI and a non-STEMI and unstable angina. And then we will also, in terms of differentiating between a non-STEMI and an unstable angina, it will be based on the serum proteins. Unstable angina does not have CKMB, a raised CKMB, so that's how we will know that it's unstable angina. And T-wave invasion looks like, as in normal ECG, QRS. So then we will have a T that is invaded. So this is the T-wave invasion. I don't know, I might actually get like this a bit. But then in terms of an ST elevation, the Q wave is quite deep and pronounced, and that is a sign of necrosis. So this is how we will identify and diagnose, definitively that what the patient is actually suffering from. And then the management of acute coronary syndromes. Say the management of non-STEMI and unstable angina is based on, we'll have start. All of this is obviously acute and immediate. Aspirin, chewed,